with public health, vital records, and vital statistics, as well as identity creation, maintenance, and deletion. The panelists will discuss the potential for blockchain to streamline medical data management, support personalized patient care, and address key challenges in data transparency and regulatory compliance. With that, we'll have Heather Flannery, who will come up and be the moderator for this.
Hello, everyone. It is so exciting to be here on day 2 of this incredible event. This is a discussion that is going to be significant to everyone here in the room. Each and every one of us is a patient. Most of us, or many of us, are or will be caregivers in our lives. This is the most intimate, profound, and sensitive dimension of the entirety of the human experience. It's significant not only economically, where here in the United States we have upward of 18% of GDP against health and life sciences spend, and we have among 33 or 37th in the developed world for pop health endpoints. All experts in this field acknowledge that the systems, and I mean that at a complex adaptive systems level, are profoundly broken, but alternative constructs have not been able to be piloted or validated. And so there's a lot of blame and shame across different stakeholder groups, across party lines, and the result is unfortunately continuously worsening health equity, profound security weaknesses affecting patients and institutions in our field, and spiraling costs and worsening outcomes. It's really a subject of national shame, in my view. My particular focus is working on a valuable cohort of our bravest citizens, our active duty military service members, our United States veterans, our first responders, and all of their immediate families, as it is the total family of these people who sacrifice and serve, including serve us with perhaps the greatest sacrifice. So a major focus of my work at AI Mind Systems Foundation, where I'm the CEO and co-founder, is our National Hero Initiative, Health Enhancing Resource Orchestration, which will provide national and transnational scale through U.S. allies with a new class of critical infrastructure. This includes the convergence of multiple exponential technologies with blockchain and Web3 at its heart, and will enable for the first time an enterprise-grade but completely person-sovereign data and AI compute stack, where decentralized and self-sovereign identity is the cornerstone of that foundation, but moving to data sovereignty, AI sovereignty, sovereignty over personal digital twins, and the ability for individual people, for we the people, to interact with technological parity with the corporations and governments who seek to serve and influence us. That means operating models, governance frameworks that can mitigate conflicts of interest with the individual person and find a sustainable win-win balance between a very complex set of ecosystem actors. In this panel today, we're going to be covering a cross-section of all the themes that you've heard discussed in this tremendous event so far. The importance of this conversation I cannot overstate enough. Myself and colleagues and many in our industry have been working intently at this intersection of blockchain, AI, healthcare, and life sciences to include social determinants, social services, philanthropic services, et cetera, at least since 2017. And the industry as a whole has been through many fits and starts, many intervals of striving and falling. But like everyone here in this room, it is those who are absolutely determined and committed to see this through to the endpoints and the impact that we know concretely are possible. So this isn't a new process. You're not going to be hearing about something that's starting now. You are hearing about something that is at its tipping point. We are finally there. And not only the technology has emerged or has evolved in necessary ways, but we have entirely new operating models that lend itself to these different kinds of decentralized architectures. I have a quick few announcements to make before we start the panel. I have the honor of chairing the Healthcare and Life Sciences Working Group here at the GBA. I would heartily encourage anyone who's a professional in that field in any capacity to please join us and participate in this work. I'm also wear a number of other hats, but at the GBA, we have launched the Coalition for Trust and Wisdom in Global Health, focusing on a low and middle income country strategy to bring these ideas around the world. I'm absolutely delighted to announce that a number of GBA member companies are all joining the National Hero Coalition as partners. If you look at the Healthcare and Life Sciences Working Group table, you'll find some announcements and some materials for your review. But this includes Guardrail Technologies, with Shauna Hoffman, that you will hear from later today, joining the National Hero Initiative as a partner to AI Mind Systems in the area of AI security and monitoring and evaluation, improving ethical risk management and clinical emergency preservation, particular focus on suicide prevention. I am thrilled also to announce that we have a partnership with BlockCube, and Rama Rao, the CEO right in the back, could you raise your hand, Rama? Runs a tremendous company, a blockchain-based clinical trial management system. And we are adopting that infrastructure to form the research foundation, the technical foundation that we will use for a wide range of new forms of health research made possible by these novel technologies, particularly advancements on decentralized clinical trials and person-sovereign precision research that is only possible with massively multimodal data. The overall thesis is that there's a tremendous amount of work that has to be done for and with enterprises, governments and corporations, but we have to achieve technological parity for the individual person. The individual person must be able to personally and independently realize the same empowerment that is a radical set of capabilities in the hands of corporations and governments. So that is the heart of the Web3 movement, the social movement that underpins the values of everyone in this room. We also have Marquis Allen, who was the original creator of the Blockchain Working Group. Marquis, are you here in the room? We were going to have Marquis make a couple of announcements. Maybe we'll do that at the end of the panel, including joining the ARPA-H Catalyst program and bringing the blockchain community into ARPA-H. So with that, I'm excited to introduce our esteemed panelists. If the panelists will please join us. And off we go. And by the way, please be thinking about your questions, because we love the audience. We love the audience engagement, and we had a wonderful opportunity that we started a little bit earlier, so we have more time to engage with you. All right, thank you very much. To my esteemed panelists, we can't wait to hear from you today. Let's start with a personal introduction, as well as any organizations that you represent, and your biggest priority and passion that intersects with the health and well-being of individual people. Let's start with you, Long.
Good afternoon. My name Long, work from Vietnam Blockchain Corporation, founder and CEO. I'm happy to be here for not just only sharing what we did in Vietnam from last 10 years, compliance, fully compliance, and also would like to expand the APEC group in the GBA. And I think with my network and what we did in last 10 years, we could support a lot for GBA growing in APEC. And happy to share with you some experience and learn from you what you are doing and what we are doing, and hopefully we could do more collaborating together after this discussion. Thank you.
Thank you. Good morning, good afternoon. I'm Dana Moore. I'm the outgoing state registrar of vital records and vital statistics for California, and my new day job, I'm the executive director for the California Utilities Emergency Association. In terms of blockchain and vital records, we were talking about every life. So everybody ostensibly has a birth certificate. There's some challenges around digital identity and having a digital vital record, but I think there's a lot of opportunity in vital statistics, and that's basically birth data, death data, marriage data. And so there's a lot of research being done, and a lot of research uses vital statistics data, and so that's where I see opportunities to ensure security in individual data.
Thank you so much, Dana. And it's a little known fact that net mortality data is absolutely terrible in the United States. So all of the things you see about mortality rates are very, very made up data, as it were.
Death data is hard to get because dead people can't speak for themselves.
As it turns out, yes. But we did just pass Halloween. We should have had an update. Okay, over to you, Cam.
Hi, everybody. I'm Cam Erickson. I'm a legislative assistant in the U.S. House of Representatives, working for a member of the House Appropriations Committee, and also pleased to say it looks like we'll remain in the majority for a member that is on appropriations. And some of my biggest priorities, as well as what I think are some of the House Republicans' priorities coming up into the 119th Congress, include the supporting in terms of our vital records and our personal health information, the government programs that are a part of that. And Heather, I'm really glad that you mentioned the VA and your HEROES initiative, because I would really like to dive into the VHA's electronic health record system and how, and I won't have nice things to say about it, but I will have nice things to say about the potential it has. And I also would like to go into some of the privacy protection aspects of any kind of personal health identifiers, which includes blockchain identifiers, because it is something that the American people are increasingly concerned about, and we must protect the patient's privacy in anything that we do. Thanks, Heather, for moderating this.
Thank you, Cam. And actually, that's a wonderful segue into the first thing I was hoping we could discuss on this panel, and that's the complicated matter of privacy and selective disclosure, and the compliance and ethical considerations in our industry. And just to give you a quick summary of the circumstances for those in the room not from this industry, and just speaking to the U.S. health market specifically, an enormous amount of public health research and clinical research is conducted on de-identified data due to compliance reasons and due to the inability to engage with individual data subjects, in part due to identity, but other matters. What this means is one party increases their healthcare costs administratively by having to have controls around appropriate de-identification, which is a sticky wicket and introduces liability and other risks, security risks. The party who wants to use that data, perhaps a pharmaceutical company, research sponsor, for instance, there are data acquisitions through intermediaries and brokers that then that occur without any awareness of the individual that data was brokered or utilized, and then they hire fleets of data scientists on their side to try to re-inject longitudinality into the data. And if we think what is blockchain in terms of longitudinality, the ultimate system for absolutely irrefutability, time stamping of everything. The implications is that costs are elevated and quality is lowered on both sides, because we can't engage with the patient in order to empower them with selective disclosure, empower them to participate economically in the massive trade of the information about them. So I would love to hear from each of the panelists on your perspectives and experience in your respective roles on how you have dealt with privacy matters, where you see some of the most high value implications for self-sovereign identity in this space. And any thoughts you have on the ethical and moral implications of today's data economy surrounding our industry. So I'm going to go in the same order because we've got a pattern going here. Long, let's start with you.
Yeah, the reason why blockchain is good for healthcare and privacy protection. I would like to talk about our X project in the COVID time. This means COVID passed in 2022. At that time, every people could not meet each other, but they want to have the certificate on COVID before flight out to the country or go into somewhere. And I was asked from the government do something from the blockchain support the current situation of the COVID with the data privacy. And I said yes, and we already did the COVID Pass application. At that time, we come to the hospital, we link to the HIS, Hospitality Information System. We encrypt every information of the patient who want to make the COVID certificate. Then we create the very simple mobile application. Then every people who come to the reception just input the information into their own mobile app. Then all will be encrypted in blockchain, sent to the reception, sent through the HIS. Then they bring back the paper who just signing with the QR code. Then after they get the sample to get the certificate of COVID, that input to the HIS system, come back to the reception and put back to the mobile app, then create the QR code for the patient. And all the information go through a system were encrypted by the blockchain that no one knows that except the patient who have the private key. And that's the requirement from the government protecting the privacy. And we are the real company who did that. And then from that, we expand to the international airport. Whenever the people who go out to the airport, they just show the QR code with the blockchain, and then they scan to the entrance door. Then that entrance door will encrypt the data, but with the private key, they was decrypted. Then they were accepted, go through the door, go to the airport, and every single data transfer on the system was encrypted by blockchain. Accepted inside the hospital, they store the real data, and outside the hospital, we encrypt everything. And that one of, I talk by the technology language, but hopefully that the real process that we did and show the real case. We are here to show what we did, not just show the idea, we show the result. And already 6,000 certificate of COVID passed already go through the system and go to the international airport.
Thank you, Long. That's very exciting momentum. And I love ideas you've shared separately about being able to scale that capability and bring it across the Asia-Pacific market, including partnering through the GBA APAC working group with our partner countries.
over to you, Dana. It was a good public health example. Okay, thank you. I usually don't use microphones. I'm loud. So in terms of vital records and statistics, first and foremost, vital records is a paper system. So you have a birth clerk who asks the birthing person to fill out a form after giving birth, completely exhausted, probably not fully there. And if English isn't your first language, you now have a birth clerk who's interpreting the information for you. For example, an individual in California had to pay for an amendment, so it's a second page to change your birth certificate. The birth clerk put her name as Water, first name, middle name, Lupe, last name, Gonzalez. Her name was Guadalupe. The birth clerk took it upon themselves to do that. So now this person has a vital record that's 2 pages, and they will always have a 2-page vital record, which instills discrimination, racism, etc. So there is some opportunity there with electronic vital records. Blockchain gets a little tough, and the reason why is that you can trace it back in terms of what's being discussed right now in vital records. And the challenge there is adoptions. Those are sealed. The only people who can open an adoption record is through a court order. Then you have, at least in California, gender change, other identity changes. We do witness protection program. There's a variety of court-ordered seal and replaces that if you have blockchain, you will completely destroy privacy for those individuals with vital records. On the flip side, vital statistics. So we were talking about poor death data. I think about 40% of deaths in the country are not fully reported. So inaccurate data, again, it's hard to talk when you're dead. So it's the informant. It's usually the eldest daughter that provides the information. If you have a family member who doesn't agree with your not sex at birth, gender, if they don't agree with a variety of things, they then have the power to change your identity. But you don't get to speak for yourself because you're dead. So death data is incredibly inaccurate. However, when we think about vital statistics, so researchers, media, the public, you go through the Committee of Protection for Human Subjects, and then every vital records entity, the state registrars, usually have our own IRBs. And in California, as state registrar, I have to read every single application that comes in. It's thousands, on top of a full day job. Luckily, I have an amazing team. So when you apply for data, you sign sort of this agreement saying, I will not reshare. So as the PI, I'm gonna look at this data. Here's the 5 people on my team. They will not reshare. We have no mechanism to say, did you really reshare that? In California, the state registrar is legally liable as an individual. You sign some paperwork saying, I understand that for every case of a breach, I am liable for $1,000 and 1 year in prison. So imagine if you have hundreds of thousands of breaches. So it's really hard to be a state registrar. So there's a huge opportunity for protection for people's data, especially birth data. California is an open state. Most states are for death data because everybody needs it. So there's a huge opportunity for protection to prevent resharing. The other issue when you're talking about economy, vital records and state registrars make all of our money on death certificates because you have to buy so many of them. So the real problem when we get into mobile vital records or digital vital records, every single state will be put out of business. Every registrar will be put out of business because you only need one. And we have to keep every single record. I have records, paper records going back to 1905. Other states, I mean, Massachusetts was the very first state registrar. They have the oldest vital record system. So we have to maintain that. We have to maintain your identity. We have to protect your identity. We delete your identity. And if you only get one vital record, we will go out of business. And then what? So we need to be able to have a system that your vital record expires. But then you're now asking people to constantly pay for birth certificates, constantly pay for death certificates. They then have to pay for the maintenance. And in my perspective, that is not equitable. And as we see changing socioeconomics and sociodemographics, you're now putting basically a tax on individuals, a regressive tax, on individuals who can't afford it. And at the county level, you can charge more than we do at the state. So at the state, it's $23. I bought my kids' birth certificates. It was $100 because I have twins. So it's fraught with nuance, and there's a lot of opportunity, but there's just so many other challenges and laws that have to be written and rewritten. In California, the state registrar oversees 900 individual laws in 12 parts of the code. No other program in health, public health, social services has that many laws in that many parts of the code. It's about 50% of our state codes. So vital records and vital statistics are a really big deal because we deal with death and cremation and everything that goes with the process. So anyway.
Dana, this is absolutely fascinating. Question for you. If it were possible to have an alternative financial system that sustained the financially sustained vital records that was driven by free market demand for data that was annotated or enriched with verifiable credentials linked to vital records, and it was a consumption base or use base of the vital records. So vital records as a service into a data economy. What do you think about that idea?
So I think there's some pros and cons. Individuals that use their vital records frequently need social services, means testing, low-income housing, every time your kid goes to school, when you sign up for health care. So you need a vital record for a lot of things. And if it's consumption-based and the end user pays for it, I mean, that's still expensive. If the holder has to pay for it, so let's say WIC. So that's a federal program that is not actually in public health, but health departments administer it. So if the federal government could pay for every time someone had to use that as a subsidy, I mean, they subsidize baby formula. I'm sure they could subsidize vital records usage. But then you look at state programs, right? I mean, Medicaid, you're looking at all your social services programs, that's state general fund. So now you're looking at tax dollars. If the individual is not going to take it on, if the institution takes it on, you'd have to make it something that's sort of like a, I'm trying to think, like a licensing, I guess it's like consumption-based when you use like Snowflake and all of those data systems that it's like a phone plan. Every time you ping it, you get charged. So the Department of Public Health in California, every time we ping our data in our infrastructure, we now have to pay for that out of programs. We normally don't budget for it. You budget for individual licenses that you pay on an annual basis for flat fee. So again, it would have to be a system that maybe it's a shared cost. So maybe the individual pays half and the institution pays half.
Well, I look forward to following up with you about that offline, because what we're working on in the National Hero Initiative and the identity construct and data economics dimensions of it has that as part of its foundation. Oh, that's good. But it needs refinement and et cetera. So very exciting. Cam, what are your thoughts about this matter of, particularly from a policy perspective, what you think ought to change, if anything, with respect to our privacy laws here in the US, There's amazing and incredible splintering. There's preemption problems. There's a lot of complexity. What are your comments for the panel on what you think needs to happen or whether legislative action in this category is not necessary?
Well, thank you for that question. I've said since I first started working on the Hill 5 years ago that privacy legislation is coming. It's not a matter of if it's coming or how it's coming. It's a matter of when it's coming and also what will be inside of it. So to that end, I think the importance of privacy cannot be understated, and I think that's twofold. I think number one, the free market solutions like you were talking about, Heather, are absolutely vital, but there are a lot of, no pun intended to that, sorry, are absolutely important, and especially with an individual's personal health information. Now, you have a lot of web of legislation going back to the 1940s that, such as HIPAA, that will actually potentially get in the way and cause liability even to companies when the legislative intent of HIPAA is to do exactly that, to protect the privacy. Sometimes solutions that do just that and are intended to do that and actually do it are running into a lot of red tape. So that's the second thing. And lastly, number three, we have to keep in mind the difference between the government's obligations under, and I'm referring to the federal government here, the federal government's obligations to differentiate between the free market solutions and government-administrated programs, such as the DHA, the Defense Health Administration, or the VHA, the Veterans Health Administration. Just to give a couple of examples that the federal government, by statute, is under the obligation to administer. Now, do they administer it well? That's a whole other panel. I think just to touch on all of that, though, just because we work for the people don't work for us, and I think that's an important thing to remind people of. There's a cultural disconnect sometimes among policymakers and among the innovators and people that actually opt to use blockchain technology for their healthcare information. And people that use blockchain for other things, whether it's decentralized finance or creative methods and artistic methods. There's a disconnect between those who use blockchain and the policymakers that are oftentimes getting in the way of that. You know, Dana, to your point that blockchain might actually be an issue with privacy, that you have some heartburn about implementing blockchain because of privacy issues. I think that's a perfect example sometimes of the disconnect between policymakers, because the whole point of blockchain is privacy. It's that the user has an anonymous wallet address or identifier where they don't even need to use their name. It's double encrypted, and they can immediately, within milliseconds, if they choose to, send that to a healthcare provider or a VA clinic, if they decide to, who also has an anonymous receiver end. And it's a trustless, encrypted handshake. And there are some amazing companies that are doing this technology. One that comes to mind is Vanadium, that is doing great work in this space. And I think that the user, even if anybody looks in, all they're seeing is an anonymous wallet address. So it really does strengthen the privacy. And that strengthens the privacy for everybody, including women who give birth, including men and women and minorities and African Americans and our veterans. And that's good for everybody. And that's the kind of technology that the government should be supporting. And that is exactly the kind of technology that the Department of Veterans Affairs should be implementing. The issue with the VA is they are very reticent to change. They are still operating on an electronic health system record data that dates back to really the 90s. And the only time that the VA will change is when Congress forces them to change. That's not like the Defense Health Agency that does an excellent job at their health data system and has been meeting all their bench lines. And I think it's just from that military mission-ready mentality that the VA doesn't have. So with the VA health system, yes, it's shameful that they're not able to implement it on time. It's shameful for our veterans. It's shameful that our veterans who are supposed to be receiving community care, if the VA can't meet access wait times or drive times, aren't able to receive that community care. And a blockchain network could seamlessly integrate the community care provider, whether that's a hospital or a clinic, with the VA doctor, so that and with the patient, with the veteran, and that gets the #1 problem of the VA right now. The VA in the business of overriding the decisions of the physician and getting in the middle of the physician-veteran relationship. So that's the main thing that we have to keep in mind, and I look forward to continuing our work on that, and especially on appropriations in the upcoming fiscal year.
Each of our esteemed co-panelists are bringing sufficient content for a day-long workshop in their own rights, and this is remarkable. I feel it necessary to respectfully disagree with a couple of points that you made, Cam. One, my opinion is that blockchain is at once the ultimate technology for privacy preservation and the ultimate technology for identity assurance at once.
I agree.
And
I completely agree.
It is the, okay, so we're actually in agreement on that.
Oh, yeah, I agree.
Fantastic.
I agree 100%.
Could I add more a little bit? Actually, with the technology view, data ownership must belong to the patient, the person who owns that data. That's more important. That's why blockchain come in with self-sovereign identity, and that help that person control their own data and take responsibility for their own, including allow another people or another hospital to see their record or not. That depend on the data owners, that's the person. And that's why before come here, I already talked to Gerard that we could do not just only demonstration, but also do one blockchain application for GBA, because we talk a lot about the blockchain, but no blockchain application from the GBA. That's what we do is we try to do these, let's say, self-sovereign identity application for every single members of GBAs, like the patient in the hospital, the same. Then, like this, we did that in the last 5 years. Then, every people that you have your own ID in blockchain, and whenever you have a record from the hospital, or you have a record from your activity with the joining events, or your ticket was expired, that easy to scan it. Then you go to another, you scan it, then easy to go to check and then see whatever your record is. And then your expiration information is there. That one a very simple example, but that show whatever you are doing, you control your data. And whatever the other third party give you the information, that's your data, and you allow them to join in with you or not. That's what we are doing.
And if I could just respond to your point and to Do's point, I think it's really important to keep in mind that this must be an opt-in system, that especially with the veteran, they will have complete control of their keys, of their data, and they could choose not to share it with anybody. And it has the opportunity to really put their information on there if they decide. And in the meantime, the VA has to be updating their health record system, but it takes the VA out of the healthcare system, and it surrounds the healthcare around the veteran, which is exactly how it should be.
For the vital records piece, vital records is completely decentralized. And then even within the states, it's decentralized. The federal government has no business in vital records. It has always belonged to the states, and it should stay that way. There is no federal registrar. And in terms of blockchain, what nobody talks about is all the vendors. So in California alone, I would have to deal with 61 different vendors who might do it 61 different ways. So what happens when I move from Orange County to San Diego County? Orange County holds my birth certificate, but most people don't know that. Most people have no clue where they were born. Most people don't know where they were married. So they have to come to the state. We are the holder of everything. Counties, jurisdictions only see jurisdictions. So if we think about vendors and blockchain, so you have 61 different vendors, different ways of doing it in California. The United States has 57 registrars, and they all have their own registrar, local registrars. The VA was actually the initiator of electronic health records, so they do have a history of innovation.
Not for the past 20 years.
I'm not saying they do now. I'm saying that they did, and there's always opportunity. But I think that we need to be thoughtful. I mean, raise your hand if you know about Epic and Cerner. Yeah, they intentionally have their systems so they can't talk. So it's a real bummer when you go between systems, and that's the same thing for vital records across the country.
So, thank you, Dana. Absolutely spot on points. I'd like to pick up on a couple of things that have been surfaced here. The idea of data ownership is legally and ethically complicated. So, for clarity, I like to refer to data subjects, which is a uniform term that describes human-centered data. Ownership has jurisdictionally varying implications, and the only uniform matter to assure ownership, individual data ownership, is if the individual brings that data into their own custody. Data that is originated or governed by other parties is subject to that party's regulatory authorities, their record retention rules, their services. And this matter that no one should permit the movement of data is also illegal in many cases. That would be information blocking, which is a new illegal action under the 21st Century Cures Act, whereby a party will be subject to the same investigations and fines as a HIPAA violation for privacy for this act called information blocking. This is aiming to achieve the part of HIPAA's vision that was data portability that abjectly failed by every measure. And the key, Dana, on what you're saying about the system-to-system, point-to-point interfaces between Cerner and Epic, for instance, we have a really significant opportunity with person-mediated and person-centered workflows, where the enterprise-to-enterprise data transmission is no longer the only or necessarily critical path. And Web3 and blockchain is the fundamental element that has to be present for that. With the privacy preservation, there is also the Public Health Authority here in the U.S. That I'm sure you're very familiar with in vital records. and that means, so you basically have standard of care, mainstream medicine bodies of law, national and state. You have clinical research and health research and the entire field of research bodies of law. And then you have the Public Health Authority. These are all distinct rules with significant implications to identity and granularity, with different levels of the ability to engage an individual data subject. So what this implicates for our infrastructure requirements is that while pluralism is a wonderful idea for technology solutions, your point about the vendors is amazing, because we actually need public-private partnerships that standardize infrastructure across our country. And individual solutions up the stack, we can have a huge ecosystem of that. But no, it is not viable or possible to create the architectures we're describing if they are done on individual bespoke vendor contracts and everybody takes some shard of the view. So with that, I'd love to hear thoughts on how all of this impacts security for patient care, and close out with some policy and data economics thoughts. We don't have much time left on this panel. We need a day-long session for this. Anybody, can I hear day-long session for this? Yeah. All right, thank you very much in follow-up. So let's talk about security and resilience from an infrastructure perspective, and what's missing and what will be ultimately needed. And then I have a last question on data economics and its relationship to data and AI sovereignty. But let's start with opportunities for improvement to security and implications that you see in that area. Let's start with you. Long.
Yeah, that's why the security is very, very big issues when we apply for the healthcare. That's why I'm really interested in the BMA model of the GBA, that how you create the maturity model that say that the healthcare platform, blockchain platform, is sustainability and secure enough.
Yep, and we are working on that.
Right.
Absolutely.
From the technology side, we did present to the government of Vietnam last 3 years that we create the architecture for not just only inside the hospital, but also linked the data between this area to another area. When the people who check the COVID at this place go to another place who will just scan it. And to do that, we need to have, let's say, one blockchain platform, but we could link the side chain together on the blockchain. That's a little bit more technology, but that's why each province, they have their own private or enterprise blockchain. Like, we could not synchronize all of the blockchain in a country or like around the world. And we need to have the separate blockchain that's called side chain in every single area to easy to control. And then we link all of side chain together, and just the head information go to the main blockchain. And that's help to protect the data around. Just talk more about technology because I'm originally from engineer, but that's the truth that we discuss a lot from the science and technology in the government side, how to secure and protect the data. That's just the data security. On the security itself, that should be follow the standard one to provide where is a node protecting. But from the blockchain side, data security should be controlled by every single different area and link them together into the main chain.
Yes.
Yeah.
It will be interesting to follow up and talk about side chains versus subnets and some of the newer architectures available now that have a different approach to that problem. Very key to the question of what does the future of blockchain infrastructure really need to look like for this industry. Dana, so security, in a nutshell.
So there's two pieces, because there's a piece I want to address for you, because you're using COVID as an example. So vital records, every state, every jurisdiction, I shouldn't say state, there's 57 jurisdictions. In law, we actually have every little piece of what has to go on that piece of paper. So when a vendor wants to give us banknote, which is essentially what your vital record is on, the vendor has to meet those laws. I think California has 23 individual features that have to be in that piece of paper. So if we think about standards and security, someone needs to go get all of the jurisdiction's laws that outline every single individual feature, what that looks like, talk to all the vendors that sell banknote. Fewer and fewer people are doing it, although Canada has some amazing vendors. So there's that translation between paper and electronic. COVID. So I don't know if everybody knows, but there are reportable diseases, mandated reportable diseases. So if you're a health officer, if you're a medical provider, you have to report a specific set of diseases. Now, it's very clear why COVID is a good example because of the recent pandemic. But mind you, the reason we get flu shots every year is because of the flu pandemic. So at what point do we start moving from COVID to other reportable diseases that are nobody's business but the healthcare provider, the health officer, and the individual? When does it stop? I mean, Ebola, HIV, a variety of STDs, tuberculosis. So is someone gonna be kicked off a plane because they have latent TB, which is not active, it's not contagious, but you still need to take the drug. So where will we draw the line on infectious disease and reportable disease when it comes to that? So anyway, two sides of security, physical paper and individual rights.
The biosecurity implications you just brought up and the decision-making and governance frameworks that need to be around those, the transparency and governance, but absolute privacy of the data subject. Thank you for that. Cam, over to you.
Thank you. I want to just touch on one main thing, which is the potential for, you see this in a lot of different things. You see it in rural broadband, you see it in agriculture issues, you see it in permitting, which is different states and municipalities having to enact their own laws, and the potential for 50 different permitting codes, which is why you need to go in with a scalpel on a lot of these things and not go in with a machete or a sledgehammer and just repeal a lot of these statutes. And that's why permitting reform is so difficult, because you are dealing with a web of statutes going back to the Securities Act of the 1930s. And I think on that end, there is a lot of opportunity for deregulation and for cutting red tape and for making it so that vendors can compete and that we're not having to deal with several of the different laws and potential contradictions like y'all deal with in California and countless other states, right? And so I think the government oftentimes is not part of the solution, but part of the problem. And oftentimes just needs to allow free market innovation and really stand out of the way. And that will also get rid of the potential, like you said, to have different vendors for each patient. It's important to remember the network that that can also help mitigate the problem, because there's one network that all the vendors could operate on. But I think that is something that we have to keep in mind and fight for, is that we need to be competitive with other countries that are doing this. We need to get the government out of the way, but we need comprehensive privacy legislation to ensure that the patient and the consumer is protected.
Thank you very much. And we are at time now. Do we have time for audience questions? We do not have time for audience questions.
How about two?
All right, well, please let this be your call to action, that if you are a professional in this field, please join the Healthcare and Life Sciences Working Group and take up these matters and aid us in moving this forward. It is a vast problem space in this industry.
No, we have no minute. We are over